You know, when people talk about perimenopause, the phrase you almost always hear is like, my hormones are going crazy.
Oh, yeah. Constantly.
Right. It paints this picture of total random chaos, just a
So,
bunch of dials spinning completely out of control inside your body.
well, and it creates a lot of anxiety, because it feels entirely unpredictable. It implies the body just suddenly forgot how to run itself overnight.
Exactly. Like it's just this inevitable force of nature that you just have to suffer through. But I mean, if you actually look at the clinical data, you quickly realize it's not chaos at all.
No, not at all. It is an incredibly precise mechanical failure.
Which is wild. And well, welcome to this custom deep dive where our mission today is to essentially reverse engineer that failure.
Yeah, we've got a really great stack of sources today.
We do. We've gathered this fascinating stack of clinical guidelines for you today from the National Institute for Health and Care Excellence, that's nice, along with the British Menopause Society, the Royal College of Obstetricians and Gynecologists, and, various medical clinic briefings.
Right. And by unpacking these sources, we're going to answer one very specific, honestly fascinating question.
Yeah, which is how exactly do fluctuating estrogen levels affect the menstrual cycle, particularly, as your body enters perimenopause?
Right, so to understand the disruption, we really have to establish the baseline first. We need to look closely at the delicate dance of a normal menstrual cycle.
Right, which typically lasts, what, anywhere from 21 to 35 days?
Exactly. And the entire mechanism relies on exposing the endometrium, which is the womb lining, to two very specific natural steroids.
Yeah.
And they have to appear in a strict sequential order.
Estrogen followed by progesterone.
Right. So during the first half of the cycle, the follicular phase, your body produces estradiol.
And that's the primary estrogen, right?
Yes. And its entire job is just to cause the endometrial lining to proliferate. I mean, it makes the tissue grow, thicken, and just build up.
Okay, so think of the endometrium as a vacant lot. The estradiol acts as the signal to, start building.
Exactly.
So let's unpack this a bit. It sounds like estrogen is basically an eager construction crew.
That's a great way to look at it.
Like they show up to the site every single month and they are just constantly building up a wall, laying down brick after brick.
Right. Estrogen is entirely focused on that growth, but, unchecked growth isn't functional. A wall that just keeps getting higher and thicker eventually becomes totally unstable.
Yeah, that makes sense.
So that is where the second half of the cycle comes in. After an ovary releases an egg, which we know is ovulation, the body starts producing progesterone during the luteal phase.
Okay, so if estrogen is the construction crew, progesterone is like the building inspector.
Yes. The inspector steps onto the site, halts the construction crew, and basically says, all right, enough building. Time to prep this space for move-in.
I love that.
Yeah, so progesterone stops the proliferation completely. It matures the lining, changing its cellular structure to make it secretory and receptive.
Basically prepping the tissue just in case a fertilized egg needs to implant.
Exactly. And if there is no pregnancy, well, the hormone levels eventually drop. Both the estrogen and the progesterone just withdraw from the system.
And when the building project is officially scrapped, the wall comes down, the lining sheds, and you have a normal period.
Right. And, the clinical data on what constitutes a normal period is often really surprising to people.
Oh, totally.
When this two-part system is balanced, the actual amount of normal blood loss is remarkably small.
Hmm.
Our sources show that a healthy cycle typically involves losing only between 30 to 80 milliliters of blood.
That is just wild to think about. I mean, that's roughly 2 tablespoons of blood on the low end,
Yeah.
up to a maximum of about 60 milliliters for the statistical average.
Right, which functionally, over the course of an entire period, translates to soaking about 9 to 12 regular sanitary products.
Which really highlights just how beautifully efficient the normal cycle is when the construction crew and the building inspector are actually communicating properly.
Right, but that communication relies entirely on one specific, totally non-negotiable trigger, which is the release of an egg.
Right. Which brings us to the shift, the real disruption. Because as a woman enters her early to mid-40s, the perimenopause transition begins.
And the ovaries start producing erratic, declining levels of hormones.
But the crucial shift here isn't just about estrogen dropping.
The most crucial shift in perimenopause is actually the failure to ovulate consistently.
Okay.
As you get older, the ovaries just don't release an egg every single cycle. The medical term for this is an anovulatory cycle.
So the ovary basically just skips a month.
Yeah. And because the ovary doesn't release an egg, the body never gets the biological signal to produce progesterone.
Weep.
The essential trigger is just entirely missing from the equation.
Hold on, I'm confused. Here's where it gets really interesting because everything you read about menopause says it's caused by a lack of estrogen.
Right.
So how can estrogen be plummeting and simultaneously overbuilding a massive wall inside the uterus at the exact same time? Why are we talking about estrogen taking over the cycle?
I know. That paradox is exactly where so much of the confusion around perimenopause comes from.
Yeah.
Because, yes, overall estrogen is fluctuating and on a downward trajectory as you approach menopause. But during an ovulatory cycle, the estrogen that is still in your system acts completely unchecked.
Ah, I see. Because there is no egg released, there's no progesterone.
Exactly.
The building inspector just never shows up to the site.
Right. Without progesterone there to yell stop, the estrogen just keeps working. It just continues to stimulate the endometrium.
Oh, wow.
Yeah, the construction crew just keeps laying bricks, creating a thicker and thicker lining over weeks or sometimes even, months without any signal to stop and mature the tissue.
So you end up with this massively thickened lining just waiting there.
Yep.
And the fallout of that unchecked building process is, frankly, what makes perimenopause incredibly difficult for so many women. Because eventually that massively thickened lining does have to shed.
It does.
And when it finally does, the result is incredibly heavy menstrual bleeding, clinically known as menorrhagia.
Right, and the impact on your demographic is just staggering when you look at the clinical guidelines. The data shows that 1 in 3 women describe their periods as heavy during perimenopause.
1 in 3. That is huge.
Yeah, and 25% of women will experience at least one severe episode of heavy bleeding.
And it's profoundly disruptive, mostly because of the sheer unpredictability of it all.
Exactly. I mean, a patient might have long gaps between cycles, maybe 60 or 90 days without a period,
Wow.
which gives the unopposed estrogen 2 or 3 whole months to just keep building and building the lining.
So then suddenly, a cycle arrives with extremely heavy bleeding, large clots, and just severe flooding.
Right. And, the clinical sources point out how doctors try to measure this.
Oh, yeah, the chart thing.
Yeah, sometimes they use a pictorial blood assessment chart or a PBAC to estimate the exact milliliter loss by, looking at diagrams of stain pads or tampons.
Right, but in day-to-day care, the real measure of menorrhagia is entirely functional, isn't it? It's about the very real impact on your life.
Oh, absolutely. The numbers on a chart matter far less than the patient's actual experience.
Yeah.
Doctors are looking for functional indicators, like, are you bleeding through your clothes? Do you have to use 2 period products at the same time?
Like a tampon and a heavy pad.
Exactly, just to manage the flow.
Yeah.
Are you waking up multiple times in the middle of the night just to change protection?
Because it's not just the inconvenience or the constant anxiety of having a public accident.
Yeah.
There are serious compounding physical consequences. Women are actually developing severe symptoms of anemia from this kind of monthly blood loss.
Yeah, and we are talking about profound fatigue, feeling breathless, walking up a single flight of stairs, or just looking really pale.
Right, because you are losing oxygen-carrying red blood cells month after month, and your body simply cannot replace them fast enough.
It completely drains your physical energy reserves.
Yeah.
And actually, there's an additional highly fascinating detail in the clinical sources regarding what drives this thick lining.
Oh, right, the adipose tissue thing.
Yes. The erratic ovaries aren't actually the only ones at fault here. Excess adipose or fat tissue can actually convert androgens into estrone.
Wait, androgens, but those are typically thought of as like male hormones, right? Like testosterone.
Right.
What are they doing in this process?
Well, everyone naturally produces androgens. Women produce them in their ovaries and adrenal glands. But fat cells contain a specific enzyme called aromatase.
Okay.
And this enzyme takes those circulating androgens and chemically converts them into estrone, which is a peripheral type of estrogen.
Meaning it is being produced entirely outside of the ovaries?
Exactly.
Yeah.
Even if the ovaries are starting to shut down and produce less hormone, if a patient has excess adipose tissue, that fat tissue acts like a secondary factory.
Wow.
It independently manufactures its own estrogen, and this estrone circulates in the blood and further drives the thickening of the uterine lining, worsening the heavy bleeding completely independently of whatever the ovaries are doing.
Mind blown. Seriously, body fat is essentially acting as an independent, rogue, hormone-producing organ.
It really is.
It's like an off-the-books construction crew building an addition to the wall in the middle of the night while the main crew is asleep.
That's exactly what it is. And it underscores why managing weight, sometimes through clinical interventions, can be a highly meaningful upstream approach to helping regulate these cycles.
Right.
because by reducing the adipose tissue, you physically reduce the body's capacity for peripheral estrogen production.
That makes total sense. So, okay, what does this all mean for treatment? If the root cause of all this chaos is the missing building inspector, the progesterone, then logically, to fix the heavy bleeding, you just have to find a way to manually put the instructor back on the site.
Yeah, and the entire strategy of medical intervention is based on that exact deduction. The underlying problem is unopposed estrogen overstimulating the tissue.
Right.
Therefore, the solution is restoring balance by replacing the missing progesterone. You artificially provide the signal to halt the growth and thin the lining.
And according to the clinical guidelines, one of the most highly effective methods for doing this is the Mirena coil.
Yes, the Mirena is an intrauterine system, or IUS. It's a small, T-shaped device placed directly inside the uterus that releases a continuous, very low dose of a progestogen, specifically 52 milligrams of levonorgestrel.
Okay, let me pause you there because the sources use the words progesterone and progestogen. Are they the same thing?
It's an important distinction, actually. Progesterone refers to the natural hormone produced by the human body, whereas progestogen is the umbrella term for any substance, natural or synthetic, that acts like progesterone.
Got it. So levonorgestrel is a synthetic progestogen designed to mimic the effects of the natural building inspector.
Exactly.
But why is a Mirena designed to deliver those 52 milligrams directly into the uterus? I mean, why not just take a pill?
Because local delivery changes everything. I mean, when you take a pill, the hormone has to be absorbed through your digestive tract, processed by your liver, and pumped through your entire bloodstream just to get a tiny fraction of it to the uterus.
Right, so you're exposing your whole body to a systemic dose to treat a localized issue.
Exactly. But the Mirena places the hormone directly on the endometrial tissue. It delivers the stop building signal right to the front door of the construction site, which keeps systemic blood levels incredibly low.
And the clinical results of that local delivery are just remarkable. The sources highlight that the Mirena coil significantly reduces monthly blood loss in 9 out of 10 women.
Yeah, a 90% success rate is massive for any medical intervention.
Absolutely.
And the data goes even further. At 12 months of continuous use, 80% of users experience amenorrhea.
Meaning no bleeding at all, their periods completely stop.
Yep.
I mean, if you've been dealing with terrifying flooding, ruined clothes, and anemia, an intervention that simply halts the bleeding sounds like an absolute miracle.
It serves as a functional cure for the symptom, achieved by directly counteracting the biological mechanism causing it.
Right.
And this mechanism, the absolute necessity of opposing estrogen with a progestogen, has implications far beyond just managing heavy periods. It's actually the fundamental cornerstone of hormone replacement therapy, or HRT, safety.
Yes, this is a critical point pulled straight from the British Menopause Society guidelines.
Oh, absolutely.
If you are going to take HRT to manage menopausal symptoms like, hot flashes, joint pain, or brain fog, and you still have a uterus, you cannot take estrogen alone. You must pair it with a progestogen.
The medical community is incredibly strict about this rule, and it goes right back to the construction crew analogy. If a doctor gives a patient exogenous estrogen, estrogen delivered via a patch, a gel, or a pill, without also providing progesterone, they are artificially recreating that exact same environment of unchecked, unopposed estrogen.
You are literally funding the rogue construction crew.
You are, and the data from the Cochrane reviews on this specific scenario is just startling.
Oh, I have the stat right here.
Go for it.
Giving unopposed estrogen over a long period increases the risk of endometrial hyperplasia, which is an abnormal thickening of the lining that serves as a precursor to endometrial cancer, to a staggering degree. After 3 years of unopposed estrogen use, up to 62% of women developed endometrial hyperplasia.
It's wild.
62%. And you compare that to just 0.3% of women who were given a placebo over the exact same time frame.
Right. It is an undeniable direct causal link. The guidelines mandate that non-hysterectomized women must take a progestogen to physically protect the lining of the womb from the estrogen.
Wow.
It's not a clinical suggestion. It is a physiological requirement to prevent cellular mutation.
So if you're listening and you're seeking treatment, and maybe an IUD like the Mirena just isn't the right fit for you, maybe you prefer oral medications, the guidelines detail other options.
Yes, they do.
You might be prescribed oral micronized progesterone.
Right, which is commonly known by the brand name Utrogestin in the UK.
And what's really interesting about oral micronized progesterone is that it is identical to the natural hormone your body produces, right?
Yes.
It's not a synthetic proxy. If you are still having somewhat regular periods, your doctor will typically instruct you to take it for 12 to 14 days a cycle.
And taking it for 14 days perfectly mimics the natural 14-day luteal phase we talked about at the very beginning of this deep dive.
Ah, right.
Yeah, you are manually stepping in to play the role of the ovary that failed to release an egg. You provide the estrogen opposition, the uterine lining matures properly, and you experience a controlled, normal withdrawal bleed instead of a chaotic heavy flood.
It just makes so much sense when you break it down. I mean, when you put all this together, the eager construction crews laying bricks, the building inspectors missing their shifts, the fat tissue running a secondary estrogen factory, it completely reframes what a heavy period actually is in your 40s.
It really does.
It's not a mystery, it is not a punishment, it's just a missing chemical signal.
Exactly. And knowledge really is most valuable when it is understood and applied. Knowing the why behind your symptoms completely changes the conversation you can have with your doctor.
Oh, totally.
You aren't just complaining about bleeding anymore. You are discussing how to best reintroduce progesterone to thin and unopposed endometrial lining.
And that shift from feeling helpless to feeling informed is exactly why we do these deep dives for you.
Definitely.
But before we wrap up, you mentioned earlier that there's one final, broader implication here that's worth thinking about.
Yeah, there is. Because we have spent this entire time looking very closely at the uterus, right? We've seen how incredibly powerful estrogen receptors are in the endometrium. Powerful enough that unopposed estrogen fluctuations can physically thicken that tissue to the point of causing severe hemorrhaging.
Which is terrifying.
It is. But we also know from the clinical sources that estrogen receptors do not just exist in the reproductive system.
They are everywhere.
They exist throughout your brain, they exist in your cardiovascular system, lining your blood vessels and your heart. They exist deep inside your bones.
Wow.
So if unopposed estrogen fluctuations can cause such extreme, measurable physical alterations to the tissue in the uterus, consider what these same wild, unchecked hormonal swings might be physically altering in those other vital organs long before menopause officially sets in.
Wow. That completely reframes the entire perimenopause transition. It's not just a reproductive event happening in one isolated organ. It is a massive systemic event.
Absolutely.
So the next time you hear someone say their hormones are just going crazy, you'll know exactly what that rogue construction crew is really up to and just how much of the body they're actually working on.